On behalf of the National Eczema Association, I'm pleased to welcome you to today's presentation, Understanding Pigmentation Changes in Eczema. Our presenter is Tracee Blackburn, PAC. Tracee Blackburn, PAC, is a board-certified physician assistant licensed in Illinois who provides medical, surgical, and aesthetic dermatology care at Medical Dermatology Associates of Chicago in River North. She has extensive experience diagnosing and treating conditions including acne, eczema, psoriasis, and skin cancer, and performs basic and intermediate surgical procedures with additional interests in alternative and cosmetic dermatology. Tracee serves as co-chair of the Society of Dermatology Physician Assistants and is the Skin of Color Education Chair for Diversity in Dermatology, advancing inclusivity in dermatology education. She is active with the National Eczema Association, where she is a longtime presenter at our annual Eczema Expo. And with that, I am delighted to introduce Tracee Blackburn. Thank you for joining us, Tracee.
Thank you so much, Nora. And I absolutely love your name because it brings a beautiful story of one of my patients. And that's all I'm going to say. But my little baby that I was able to help her and her mom and her sisters and her whole family get her eczema under control. And she's very happy. And that's all I'm going to say. So Nora, I love your name. All right, thank you so much for that introduction. And I'm so happy to be here on behalf of NEA or NEA. And as a personal, I am a personal caregiver actually for my stepson, who actually is 19 now, and he was born with eczema, and we have gotten his skin under control, and so now he's grown and he knows how to take care of himself, and I'm so happy that I had a little part in that. So I am going to share my screen. And hopefully everybody can see that. And I would like for this to be a little bit interactive. I'm not sure about the chat, button that is available for you guys, but I'm sure that they will help on the back end. So let's get started. We're going to talk a little bit about understanding pigmentation changes in eczema. And the reason why that's important is because I still have a lot of patients that actually come into the office, and one of their main concerns is, how do I get rid of the spots, the dark spots, the pigmentation? Spring is coming, summer is coming, so we want to make sure that we can get it under control. But I always say you have to treat the inflammation before the pigmentation. Here are my disclosures. Now, when we think about eczema, there are different types of eczema, right? Of course, we all know that the main type, or number one, is atopic dermatitis. But underneath this also is contact dermatitis, nummular eczema, follicular eczema, seborrheic dermatitis, which actually is a condition that if your barrier is a little bit inflamed or warped, then there are secondary measures that actually come into play that make it a little bit more inflamed, and that's where we get their seborrheic dermatitis, aka dandruff. And so lichen simplex chronicus, so we'll go over a little bit into detail with that. And then pityriasis alba is another one. And so I will have some examples of all of these types of skin inflammation that you'll see. And the list goes on and on and on, right? Now, I would like you to think now, when you think of eczema, think of your skin condition, think of atopic dermatitis, what is the first word that comes to mind? And this is when I usually like to look at the chat button and kind of see, but I'm not able to see that. So if maybe Nora can kind of yell out some of the things that people may say, if that's possible.
Sure. I'm seeing itchy, the first one to come in. Dry, scaling, itch, and I'm seeing rash as well.
Okay, excellent. Thank you guys for participating. And so here we have this graphic that shows all of that, right? We have itchy, irritable, illness, disease, hypersensitive, practitioner, psoriasis, right? Because sometimes there's a misdiagnosis possibly, right? Seeing your dermatologist. The list for this goes on and on. But the one thing that I don't see here is pigmentation, right? And so that also is a variant of what can happen to our skin when we have inflammation and atopic dermatitis. So pigmentary changes do matter. There is a difference between hypopigmentation and hyperpigmentation. Hypopigmentation refers to the loss of pigment, right? So that means that lighter patches of the skin are seen. And this occurs when melanocytes, which are cells responsible for pigment, are damaged or melanin production is disrupted. And hyperpigmentation is the darkening of the skin, often caused by increased melanin production in response to inflammation or injury. But both can result from eczema, depending on how the skin heals after a flare. Now, depending your skin type, whether you are what we call a skin type 1 through 3, or lighter skin types or darker skin types, sometimes you can have a little bit of what we call erythema or redness or pink, and sometimes you can have the darkening, what we call violaceous or hyperpigmented patches, and also light patches can be in both skin types. I really love this photo here just because it is very diverse in its depiction, but it also reminds me of Burberry, which is one of my favorite products. So how eczema, inflammation, and scratching contribute to pigmentation changes? So we know that inflammation can damage skin cells and disrupt melanin production. But guess what? That inflammation is not always seen. Sometimes that actually is underneath the skin, because there may be some types of eczema or some types of inflammation that you just see the change of color and you're like, what is that? Or it may be a little bit dry, but it necessarily isn't itchy. Then if it is itchy, the scratching further injures the skin and intensifies inflammation, increasing the risk for post-inflammatory pigment changes. Now, when we have chronic scratching, from chronic itching, or what we do as far as rubbing or picking or things like that, that can thicken the skin. And that's where we get to that word lichenification, or some will say that leathery skin that some can develop, making the pigmentation changes more noticeable and actually can cause a little bit more time to improve because of the thickening of the skin. So I know I've said this word a lot, inflammation, and I'm sure you've heard it a lot as well. But what actually does that mean, right? So we know that atopic dermatitis or eczema can come from this inflammation. And what that means is that there is a dysfunction in our immune system. Our immune system is overreacting in a way, right? But that can come from different triggers. There can be a genetic predisposition. Sometimes that can come from our environmental triggers, as far as like allergies and irritants. Or if our skin barrier is disrupted, then we can have secondary triggers like bacteria and yeast. And of course, if our skin is inflamed and we have that itching, then we scratch, and we all are aware of that scratch itch cycle. And then of course with that disrupts the barrier, and then it's just that big ball of fire that happens. Now, I really love this photo here because it shows all of the things that you may have been recommended or prescribed for all of these different things, right? So if we have itching, of course, there's education behind that. We say, oh, stop scratching. But you can't stop scratching, right? Because this is something so much deeper. But antihistamines, we have wet wraps. There are, they say, avoid your allergens and your irritants. Sometimes that is unpredictable. But if we have some itching, we can also use what we call topical corticosteroids or calcineurin inhibitors. Those are your creams. And then there are times where we are literally driving into our patients, moisturize. And as adults, we know how important that is, but try to put a lotion or a cream or an ointment on a little baby or a kid, and they're like, oh my God, no. But we know how important it is because also through the skin barrier, we have what we call transepidermal water loss. And so that's where we want to kind of retain the moisture in our skin so that it can have the opportunity to heal. So as we know, we see what's going on in the skin, but this is so much deeper. So let's move forward and talk about this immune dysfunction. So again, this is your skin. This is the surface of your skin, right? And just to kind of orient you to this picture, we are going from non-lesional skin. And in non-lesional skin, that means that you can't really see what's going on the surface, but you know what? There's this party that is starting to kind of bump, right? Like behind those closed doors, you know that there is a party about to happen. And so when we have these inflammatory cells or these proteins that come into play, this is when we start to have that acute lesional stage. So we start to kind of have that itch. We start to scratch, and then that disrupts the barrier, as you can see here. And then with chronic itching and scratching, this chronic lesional stage happens, and this is where we have that thickened skin. And as you can see, although all what we see is on the surface, these are what we call cytokines, right? Interleukin 4, interleukin 13, 31, all of these things are what our medications are focusing on to kind of calm it down and shut that party down. So these are called cytokines, and what cytokines are, they're like proteins that help to kind of signal between the cells. And so all of this is going on. So we can't just slap a cream on it sometimes. We have to dig a little deeper. So here we go. At NIA, when I go to the Eczema Expo, you know, I love those buttons that say, tell me to stop scratching, or you can't tell someone to stop scratching. It's just something that is so hard to do, right? So I put this little cartoon here, and it says, the vet said, I'll stop him from scratching himself. The vet said, it'll stop him from scratching himself. So I got one from Brian too. And Brian just so happens to be my husband with a Y, but she put the little, I guess, what do you call this, a muzzle or a harness or apparatus so that the dog can stop scratching. But as you can see here, Brian's over there watching TV scratching too. It's kind of hard. So how changes in pigmentation develop? So of course, I mentioned this before, we have our Fitzpatrick's types. We have Fitzpatrick's types 1 through 6. Our darker skin tones, which are Fitzpatrick's types 4 through 6, have more active melanocytes, making them more prone to post-inflammatory pigmentation. And as you can see here, this is the comparison of lighter skin types to darker skin types and how much more deeper that pigment can be, as you can see through the skin and up to the surface. So greater melanin response means both hyper and hypopigmentation, and those who have darker skin tones it's more prominent and longer lasting. So frequent or severe flares, chronic eczema, excessive scratching can increase the risk regardless of skin tone, but affects more it's actually more visible in melanin-rich skin. So there's two different types of melanin pigment produced by the melanocytes. There's eumelanin, which is the dark brown pigment, and pheomelanin, which is a red or a yellow tint, right? And then those with darker skin tones can have eumelanin, hence are different shades of brown skin color, whereas those with lighter skin tones have the pheomelanin, as you can see here. And basically what this is like, this is your epidermis and the layers that are seen within the epidermis or your skin. And so these granules are more densely packed, and that's why you have those, the darker pigment, where here it's not as densely packed, it's a little bit more scarce, and that's why you have those lighter pigments, or they're not I guess, prone to the darker hyperpigmentation. So what happens when you have chronic inflammation? Well, this is where we get into lichen simplex chronicus. And this is a common form of chronic neurodermatitis that presents as dry, patchy areas of skin that are really scaly or thick, or what some people will say, that leathery type of feel. So the background is usually it's usually a secondary skin lesion where you have thickening of the skin, exaggerated skin lines, and it can develop from constant rubbing or scratching. I literally had a patient in the office the other day, and he's been on medication and he's doing really well. And then I looked at his back and there's this one side, and I was like, what are you scratching with? He's just like, how did you know? And the skin has a very thick, it has a thicker texture to it, but that's just his little spot that, you know, he can only get to, but everything else was clearing. And so I just want to, you know, when you have that, sometimes there are some things you can do to kind of put the fire out is what I recommend, whether it's a cool compress, whether it's moisturization, or whether it's just focusing on something else to kind of, you know, make your mind go somewhere else so that you're not focusing on that symptom. But sometimes this can be reflective of maybe a psychological component. It can be habit forming, and secondary causes, again, can be because of, you know, eczema and the chronic itching. So this is what it can look like, and you may have seen this or you may be experiencing this, but on our lighter skin tones, again, we have that erythematous or pink, scaly, thickened skin, and on our darker skin tones, we have that purplish or what we call violaceous or hyperpigmented skin. So here's a patient that I had, and she presented to me, and she had this thick, leathery, hyperpigmented skin, right? I actually performed a couple of biopsies just to confirm her diagnosis, which was consistent with atopic dermatitis and lichen simplex chronicus. So after we started to treat her, though, as you can see here, she has hypopigmentation. Well, the reason being is that the topical cream that was given was a steroid cream. And what steroid creams do is they help to kind of decrease the inflammation, which helps to stop the pigmentation. But we can't use steroid creams for long periods of time, because what it can do is it can thin the skin, and then that causes hypopigmentation. So at this point, we want to discontinue that and maybe give her something for maintenance treatment so that this skin barrier can heal overall. Her pigment did come back, but these are reasons also why we need you to come back into the office to make sure that what is recommended and that you're using it appropriately, and making sure that you're not having any adverse reactions or side effects. This is a example of what we call follicular eczema and hyperpigmentation. And as you can see here, around the, you know, hair follicles, every hair follicle is lined with what we call melanocytes, or those cells that create the pigment. And every little follicle has this dry, inflammatory component. So I call this follicular eczema because it's around the follicle. And of course, that causes the pigmentation because of the inflammation. Here we have a hypersensitivity reaction or contact dermatitis. So this is a patient that presented to the emergency room. Now he's an African-American patient, probably a skin type 4 or 5. But as you can see, he has a little bit of the redness and pink and yellow, but also hyperpigmentation as well. Now here is seborrheic dermatitis, what I mentioned is AKA dandruff, right? But again, the skin barrier is affected because of you know, dryness and inflammation. And then what's present on everyone's skin is a yeast called Malassezia. And what that does is it looks for the disruption in the skin barrier to say, hey guys, party over here. We all have Malassezia, but it's looking for a party to go to. And so this is what can happen. So not only can it be in the scalp, but it can also be on the face, sometimes chest, back, ears. And so this is seborrheic dermatitis, and you can see that she has hypopigmentation because of this condition, and she is an African-American patient as well, but she also has this violaceous hyperpigmentation. Now here's a picture of post-inflammatory hypopigmentation. So this patient is not actively inflamed, but may have, after treatment, everything has calmed down, but they have the skin that is lighter than their skin tone. Sometimes we can get the skin to repigment. Sometimes it is considered a type of scarring. So oftentimes in our babies, we'll see them in the what we call our antecubital fossa, or this is the inside of the elbow. But once everything once everything improves, then you can see the pigment starting to come back. And then pityriasis alba is another type of atopic dermatitis or eczema. And a lot of times these patients are not itchy. Here's a little kid that may have come from summer camp, and all of a sudden we're seeing like these light patches on their skin because they're not tanning, because underneath the surface there is inflammation happening. But on the surface we see what's going on. And usually this can be treated with a great moisturizer, sometimes non-steroidal options or anti-inflammatory options, but little kids and also adults, as you can see, it is hypopigmented in both of those areas. But once treated, the skin tone does return. So how do we treat? I know that's everybody's question probably this evening. Well, there's a strategy to this, right? We want to definitely decrease the inflammation. And with that, you will see your pigmentation improve. So controlling the inflammation early with just overall skincare and sometimes prescribed treatments. Avoid harsh skincare products or excessive exfoliation. I have patients that feel that if they scrub or exfoliate, that they're helping their skin to kind of cycle, but it actually can cause more friction. More friction causes thicker skin. Thicker skin can cause hyperpigmentation. And so it definitely is a cycle. So when I say stop scrubbing, they are like, what are you talking about? It feels so good, number one, but I feel like I'm getting rid of the dead skin. But it actually can be igniting the fire. Moisturize. So moisturize regularly to maintain skin barrier function and reduce flare frequency. Sun protection. We want to make sure that you use sunscreen daily. UV exposure can darken hyperpigmented areas. But not only that, when you have UV exposure and you have the sun, you also have heat. And heat can cause the vascular component underneath to activate, and that feeds the pigmentation. So we always tell our patients, stay away from like a lot of hot showers, hot water. Even if you are having active inflammation, you want to kind of calm down from saunas and steam rooms. We know they make you feel good overall. And I tell my patients, if you're having a good day, go ahead in there, but we have to cool the skin down afterwards so that it doesn't have an opportunity to what I call percolate. And then of course, we want to try to put the fire out. So if there is active itching that is happening, what can we do to put the fire out? Is that a cool compress? Is that an ice roller? Is that, sometimes I recommend the spring water spray, or you pick the cream that works for you. And don't forget, a little bit of Vaseline goes a long way. So while there is active eczema, while the active eczema may resolve, pigmentation changes often remain as a sign of past inflammation, which is why we call it post-inflammatory. So the skin takes time to regenerate and normalize the melanin distribution. I tell my patients it takes about 4 weeks for your skin to cycle. So once we get down the inflammation, you'll start to see that pigment kind of normalizing, which is why it is so important that once you get to that stage where your eczema is under control, it's important to keep it that way. And that way you'll be able to work on the pigment. And melanin imbalance lingers even when inflammation subsides, so particularly in areas of repeated trauma. So even if those areas, I like to say we treat to complete, meaning we want complete clearance of the inflammation, that area can spark up again, right? So we want to make sure that we can keep our skin as happy as possible, but I know it is unpredictable. So once you find your jam and once you find that recipe for your skin, let's stick with it. So the goal is to focus on healing and restoring the skin barrier, knowing your triggers if possible, avoid any known allergens, although I know every day is a new day. Listen to your skin, meaning a lot of times these things can come from the inside out. And I always say, you know what, even when we talk about like gut health and things like that, this is what I say, listen to your skin. If there's something on the surface, think about, did I come into contact with something? Did I eat something different? Or, you know what, was I in a very, an episode where maybe there was a little bit of stress, right? Your skin will react. And I'm sure if you've had eczema for a long period of time, you already know what some of those triggers can be. When you are introducing products, because a lot of times we got TikTok, Instagram, YouTube, all of these things that you're like, oh, do I need that? Do I need that? Should I do this? And then there's like these 7 to 8 step protocols. Introduce one product at a time, maybe about a week. Sometimes you can have an immediate reaction if you're allergic to it. Sometimes it can take 3 days. So I say, you know what, after about 72 hours or at least a week and things are good, you can go ahead and start something else and add to it. However, don't think that when you're treating pigment that it's going to go away overnight. So again, your skin cycles every 4 weeks. You got to give it time. I encourage taking pictures of the areas so that that helps for you to see where you started and where you're going. And then do your research, right? Ask questions prior to procedures. Be your own advocate. If someone is not explaining something to you, then make sure that you understand so that you're able to maneuver. If something happens and you're at home, call the office or get in touch with the office and say, hey, is this possible? I actually have patients that literally fact check me with Chat GPT sometimes. And I'm like, are you kidding me right now? So they use Chat GPT and like, well, Chat GPT told me that you only use it twice. And I said, yeah, but I said use it twice a day for 2 weeks or twice a day for 2 months. So ChatGPT is a good option for some to get you, some fast answers. But always look at listen to your providers, and then they can help you. And if you have a provider that does not listen, then keep searching for one who will listen to you and advocate for you as well. So treatment options. Let's talk about medical treatment. There's so many out there, right? We have our topical corticosteroids and calcineurin inhibitors. We have our topical anti-inflammatory non-steroidal options. We have biologics in form of pills, in injectables, and also JAK inhibitors, UV therapy, or what we call that light box or phototherapy. Of course, everybody asks, I need some bleaching cream. Can I get some hydroquinone? Hydroquinone is not my number one, just because it lightens everything and it's not good for long-term use. But if there is a spot that is really bothering you, I will sometimes offer it, but it's not my number one go-to. We have so many other things that are out there now. And let's talk about that. Complementary treatment, right? These are all the things that you're going to see over the counter or in products that may help, right? So we have niacinamide, azelaic acid, vitamin C, licorice root, umbilica. We have soy. Bio oil is one of the main things that you'll see this at like Walgreens or CVS or Target. It's just like this nice little orangish oil. It's not irritating, and it spreads really well for large surface areas. Mela B3 is a proprietary blend from one of our over-the-counter products. Tranexamic acid, kojic acid. I already mentioned niacinamide. Sorry that's there twice. Bakuchiol. Then there's procedures that you can do, microdermabrasion or hydrofacials, which are cosmetic procedures that gently exfoliate the skin. But of course, you want to make sure that your skin barrier is intact, especially before you get into chemical peels, microneedling. And then there's other complementary procedures that you can do, or therapies like BMT, which is behavior modification therapy, and even acupuncture. I remember that Nia, when they were in Chicago, had a workshop where there was an acupuncturist and they were actually treating patients at the conference, which was my first encounter. And I absolutely love that. So look for some options other than just, topicals and things like that, just to help with, how to cope with inflammation or inflammatory flares. The key is to treat the inflammation before you treat the pigmentation. And we know that there's an emotional impact of visible pigmentation changes. Like I said, a lot of my patients come in and they're like, how do I get rid of the dark spots? Oh my God, again, springtime's coming, summertime's coming. And so it can lead to self-consciousness, anxiety, lowered self-esteem. Like literally, this is everything that is going on when we are dealing with atopic dermatitis. Again, starting with the immune dysfunction, nervous system imbalance, impaired skin barrier. Of course, there's that genetic predisposition, environment, which is so unpredictable. Sometimes, again, we talk about like excessive exfoliation or feeling like I have to be, extra clean, things like that. And so that's causing more disruption. And I always use stress as the last thing. We know that it's underlying, but I don't want to harp on it as much because the days and the times that we live in, it's always going to be a little bit of that underneath, right? So supportive counseling can help manage the psychological impact, and skin normalization takes time. Patience and consistent care are key, and a wonderful relationship with your dermatology provider that you can trust. It truly is an emotional roller coaster, right? We have the flare, we have the frustration, we have the treatment, we have the reset. Oh, we got it, it's good, right? The time it takes to get to that reset, right? It literally is like, this is one of the cartoons my daughter likes. What's it, Inside Out or Inside Out 2? All these personalities or all these things that are going in our head, but that truly is an emotional roller coaster. But not only that, the research. Patients are becoming more and more advocates and becoming more savvy about how they want to be treated, about how you want to be treated, right? In regards to, well, what about this? What about that? How can I do this? And I encourage patients to come to me with information, of course, within reason, because we have, a time frame, but we have a relationship. So whether that's seeing me every month or every 3 months, bring to me what you've been reading and what you've been searching so that I can look at it as well and make sure that it's sound advice. And then, of course, the cost. The clothes, the wet wrap, the supplements that we take, the foods that we can and cannot eat, right? All of these things cost money. Those, the right soap, the right lotion. So all of those things we take into account as well. But the main thing that after all that we've done, right, is the results. So I really love the fact that once we get, again, your skin recipe, that you get the results that you're looking for, and it takes time. Everybody is on their journey. And so I'm here to help along the way. And that concludes my presentation.
Wonderful. Thank you so much, Tracee. I think that was really informative. And also, I think we always speak about sort of the mental health aspect of these as well. And I know sometimes you can feel like whether you're on that hyperpigmentation side or hypopigmentation side, or maybe both, that you're not alone, that this is normal, and hopefully have some good tips to help you in your journey with eczema and with pigmentation changes as well. So I really appreciate your presentation. I think we have time for just a couple questions here. Speaking of that sort of hypopigmentation side of things, I see a question from the audience that says, is it possible for the pigment to never come back? My ankles have been hypopigmented for a long time, and it's more prominent in the summertime. So what would you say to that community member?
Absolutely. I think it definitely depends on the amount of time that inflammation was there, or how inflamed everything was before you were able to get treatment, because it can get to the point where it is considered scar tissue, like especially ankles, as I saw the depiction where we had the African American and the Caucasian patient. And so that area is a very high friction area. Not only do we tie our shoes around that area, we have our socks. Also, if you're into yoga and all of that, it's constant friction. So chronic inflammation that you may have not gotten treatment soon enough, or, again, it's that constant friction. It can cause a little bit of scar tissue, and there is a possibility that all of the pigment may not come back. But if you can get that skin as soft and not as thick, it'll definitely feel better, and it won't have as much maybe that excess lines. You know how sometimes it looks like very linear. So you can get it to improve in texture, but color may not always come back.
Thank you.
Early intervention is going to have the best outcome, but we don't always have that luxury, right? So.
Yeah, absolutely. Yeah, and I think that was something I was curious about too. So it sounds like, if there are certain body parts that you see as more prone to pigmentation changes, and is it really those high friction areas where you see pigmentation, or is it just kind of everywhere on the body is sort of an equal chance in your
everywhere on the body is. I mean, some people definitely have those like common areas for eczema, right, are going to be like your inner part of your elbows, back of your knees. But then guess what? We also lean on our elbows a lot, right? So there may be hyperpigmentation there. Or even if we're washing our hands a lot, or if it's really dry, the skin on our knuckles get really thick. The neck is a thinner skin area. So even though it gets really hyperpigmented or things like that, like a lot of times or hypopigmented, once the inflammation calms down, you'll see that pigment come back. But some areas that are thicker take longer.
Okay, interesting. And then I see kind of a follow-up question from a community member here, Crystal, in the chat. If the skin becomes scarred, so like as you mentioned, sort of there's that distinction between scarred and what is healed, is it impossible for it to be healed or improved, or to see any, I guess, measure of improvement there on scarred skin?
That's a great question. A scar, there's different types of scars, right? So there's a scar where you can have like a scratch and it literally is just darker skin or lighter skin, right? But then there can be a scar that is thicker and what we call hypertrophic. It has a little bit of thickness to it, or keloid scar. So there are things that we can do to kind of minimize how thick the scar is, and then you can start to use creams or modalities to laser treatments to help improve the pigment. So I think it depends on how long it's been there, how thick the skin is in the area, but I never say never. We will always try.
Absolutely. That's great. Thank you so much. All right. Well, I think we've just about come to the end of our time here, but many thanks again, Tracee, for helping us better understand pigmentation and changes in eczema. I'm seeing lots of comments in the chat saying wonderful information and presentation, and that they really needed this. So we know that this is a question, a hot topic on many of our patients and caregivers' minds, and hopefully you were in the audience able to take something valuable from this experience and combine that research and those resources and just get the care that you need for if you're experiencing pigmentation changes here. So thank you to everyone who joined us today. You can continue your eczema learning at nationaleczema.org, where you'll find trusted resources, upcoming webinars, and recordings of past sessions. You can also register for future webinars. We have some great ones coming up at nationaleczema.org/webinars. So on behalf of the National Eczema Association, thank you for being here, and we look forward to seeing you at a future NIA event. Thank you.
Thank you, everyone. Thank you for joining. Have a wonderful evening.